My case was how should clinicians respond to language barriers that exacerbate health inequity? My case overview is about MM and her diagnosis. MM is a 13-year-old girl with limited English proficiency, which also is known as LEP. She visited the emergency department 3 times in 1 week due to abdominal pain. On the second visit, communication was limited because both MM and her father did not speak a language supported by the interpreter phone service. Dr. J, the resident physician, relied on broken English to assess MM and discharged her with a diagnosis of gastroenteritis. 2 days later, MM returned in septic shock from a ruptured appendix, which required emergency surgery. This specific case shows the profound consequences of inadequate communication and language services in healthcare. Some legal considerations in this case are Title VI of the Civil Rights Act 1964. This act specifically mandates that patients with LEP, limited English proficiency, must be provided access to language services in federally funded health programs. This act was ignored when Dr. J relied on broken English and did not continue to find the right interpreter for their language. Lau v. Nichols, 1974, which is affirmed the obligation to ensure meaningful access to services for individuals who do not speak English. Institutions are legally obligated to provide professional interpreters, and a failure to do so can lead to legal liability. So with the Title VI and the legal case, these are just some specific legal considerations that can be applied to this specific case of MM and her diagnosis. Some ethical considerations are justice. Patients with limited English proficiency should receive care equivalent to inequality to that of English-speaking patients. So regardless of whether or not a patient can speak perfectly English or have broken English or do not speak English at all of those types of patients have to be getting the same type of treatment because of justice. Denial or inadequacy of services due to language is a form of distributive and relational injustice, which is something that the case described. Non-maleficence is when harm is avoided, but in this case, harm was not avoided and instead was caused due to inadequate communication. Autonomy. Informed decision-making is compromised in this case because there is not proper communication and comprehension. And this can be due to the patient not understanding she can't make a decision for herself or her parents since she is a minor. What needs to happen? In cases like this, increased availability of trained interpreters, especially for rare languages and dialects, need to happen, and educating clinicians on effective use of interpreter service and how to communicate across any language or cultural barriers. In the article, it did say that a lot of clinicians know of the interpreter services, but they don't know how to correctly use them, and that could be an issue. And something else that needs to happen is strengthening institutional policies on limited English proficiency patient communication. This can be done by mandating interpreter use in all clinical encounters involving LEP patients. So every time there's an encounter, there needs to be interpreter use, and enforcing that with protocols for escalation if interpreter services are unavailable, which if this was mandated, then this could have solved the issue because there would have been a solution for escalation since the interpreter services were not available in MM's case. Something else that needs to happen is recruiting bilingual clinicians and support language concordant care. What language concordant care is basically when both the patient and clinician speak the same language. This can make the patient feel representative and more open to voice concerns because they feel some sort of representation and they feel like they can confide in the clinician as they might also be culturally connected due to speaking the same language. Stakeholders and viewpoints. A couple stakeholders are Emma and her father, and they expect clear communication, understanding of symptoms, and equitable safe care. Dr. J, concerned about patient safety, frustrated by lack of effective interpreter access, but can also be seen burdened by a busy emergency department environment. The hospital administration, they have to balance the cost of interpreter service with compliance and patient safety expectations. Interpreter service providers, they have to advocate for adequate staffing, resources, and recognition of their critical role. Policymakers have to ensure equity through enforcement and funding. Class discussions. Some questions that I asked the class are, how can hospitals improve access to interpreters for less common languages or dialects? What should a clinician do if no interpreter is available in an emergency? And to what extent should healthcare providers be held personally accountable for negative outcomes from language barriers? Some final thoughts are language barriers are a driver of health inequity, which means they are not getting the same equal health treatment. Legal and ethical duties mandate interpreter access. True equity requires systemic change, clinician awareness, and cultural humility. Care should be designed with justice and inclusion at the center.